focused course which is going to deal only with one particular step of cataract surgery, and that is how we are going to deal with the situation when you don't get a good crack. So we have eminent speakers, Dr. Naren Shetty, Dr. Meenu Mathur, Dr. Kudlu, myself, Dr. Amit Porwal, the Chief Instructor, Dr. Jeevan Tityal, Dr. Haripriya Arvind, and Dr. Sudeep Das. So till we get our co-speakers, we'll just take 1 minute to arrange. So our first talk is by Dr. Meenu Mathur. When I'm not able to crack the posterior plate of a hard cataract, what do I do and how do I deal with it? So Dr. Meenu was an IOL trainer in Arvind Eye Hospital, Madurai. He is my mentor and teacher, and he is now practicing in Trivandrum in Chaitanya Eye Institute. And he's got a huge experience. He's got a huge fan following of many people who have learned cataract surgery from him. So over to you, Dr. Meenu, sir.
Yeah, good afternoon, everyone. First of all, let me thank Dr. Amit for this opportunity. This is a popular course which has been running in AIOS for some time now, because this is a very focused topic. So, in chopping, what all happens? Because chopping is one major problem. We will change this to the other. Mirroring. So, without wasting time, I think I'll start off. So, while cracking the posterior plate, we have all seen, in India we don't have dearth of this hard cataract. So, we all see grade 4, grade 5 cataracts, and we tend to do phaco because we need to do phaco on that. So, there is a particular technique for this, and why it is not cracking? We are not doing it right. That is the first thing I need to tell. So, if I do it right, if it is not happening, then we need to change the technique. So ideally, I would want a pupil to be dilated very well. So this is a really hard cataract. So I will stain the capsule with the trypan blue so that I can see the edges of the capsule margin. That's very, very crucial, because while we are chopping, we may hit on the capsular margin later on. You will lose track of the rexes. And slightly larger than regular, because these capsules are stiffer than what we think, and the whole bag is stiffer than we think, and then these lenses need to be split very much, and that is why we need to have a rexis bigger so that you don't exert too much of pressure on the bag. So now I take off the epinucleus part a little bit and then go into the center and widen it a little and go deep. So this is where I'll go into the center, and this chopper is 2 millimeters long. Not very scary. Don't be scared about long choppers. Nothing is going to happen. So I am splitting in the periphery and coming to the center, and once I do a 2 or 3, I get a gap there. So once this gap is there, see the depth into which the nucleus is being buried into, and when the nucleus is being separated, it may lose hold. Then go further into the nucleus and make sure it is held very well. That is the first thing. Second thing is to use the sharp chopper very efficiently to go into the depth of the chop which we have created. So a chop may be incomplete, but then we need to go further into the depth of that chop with the needle, with the chopper tip, and then separate further. That is how you can separate in steps, so that you don't have to separate very widely. And then you can identify the posterior plates, the lamellae which are not separated, while the hold is very strong, and individual lamellae can be separated. So this is the crucial 2-3 points which we need to make sure that you are doing. While this is happening, the pupil should not become small. If the pupil, most of these cataracts come with smaller pupils, they don't dilate very well, or they tend to constrict off very fast during the procedure. You take more time, there may be irrigation, there may be fluttering of the iris, all that can bring down the pupil. If the pupil comes below the rexis size, I will stop and put in iris hooks or a ring and see properly while you are chopping. That is one most crucial. So this we have tried and it has not happened. Though then we need a plan B. So in plan B, it should work. So my plan B, it almost 100% time works. So how does it work? So in a hard cataract, so I go to the depth so that I can see the red glow there. So I try to crack, but still if it doesn't crack, you focus on the periphery of the lens. So I hold the nucleus, the periphery chops. So I don't insist on the central chop at all. So go to the periphery and in the rexus area itself, but make sure the periphery cracks. So peripheral full thickness cracks are made. That happens very easily. The posterior plate is thicker and more leathery towards the center, not in the periphery. So this happens, and keep on doing it all around. And it depends on the size of your tip. This is a micro tip. We can use larger tips that holds much better, but then the chamber will not be that very stable as we want it to be. So according to your machine, how much it can hold, have vacuum. You don't have to have 500, 600 vacuum in all cases. You can have 300, 350 and easily hold well and chop. And now it has been chopped. Now see what happens. It is held and brought towards the center. And there it is partly loose, and I am eating it off at the rexus margin. Eating it off from the neck. So the peripheral part which was there in the bag gets eaten off. You can get the assistance of the chopper, or you don't have to. You can just eat through. But don't do it in the equator, close to the equator. Bring it, move it towards the center within the rexus margin, and then eat it off. And if it is larger, you can subdivide it, make it into further smaller pieces, and then 360 degree this will happen. And once that happens, you will end up with a thin disc with an intact posterior plate. That doesn't matter. Once you hold it or use your second instrument to tap it up, it comes up and it is free. And very important to use sodium, the viscoat, or you can use the Indian company's dispersive viscoelastic on and off. So this mostly works, almost always works. But the pupil, again I am telling you, in this case also, pupil should not become smaller than your rexus margin. So if it becomes smaller, always use iris hooks. So this is one case where this is a high myope. They tend to have very large, very hard nuclei, and they have calcifications. If you have noticed, they can have calcifications, and rexus is a mandatory thing. So if you lose rexus, all this is gone. You cannot do all this. So don't run into these calcifications. And then now when I'm chopping, when I'm closing towards the center, see that white thing which is down below there. So if you think that there is a PC rent, the good thing about this technique is that the whole nucleus is retained connected till the end. So if it is there like that, it usually does not drop through a small opening or a small piece rent. So if you have multiple small pieces, you tend to drop off these pieces. So this is another good thing to do when you suspect that the PC is open. Sometimes there may be calcific plaques there, sometimes it may be open. So you don't know, So I am taking this nucleus out of the bag, and then the separation happens in the supracapsular area here now. So this is to reduce the split or the separation forces in the capsular bag if you have a weak capsule or an open capsule. Still, the center I have not split, but the peripheral chopping is happening. So this technique has won a Best Video Award in the ACRS in the early 2000s, I remember. But still this holds good for our kind of very hard cataracts which we have. Now I have finished half of the nucleus and I see this white plaque there. But then I press on it, I can see that there is capsule there. So it is not a piece rent, so I am very confident now push the nucleus back into the bag. But still I can even complete the chop here because it is not so very hard. See, I hold it, and because there is space in the bag now, it can be separated widely. But while separating, don't insist on one full separation in one stroke. Partly it is separated, stop there, go in further with the chopper and separate less, little by little, so that you don't have to stretch widely. So that is one crucial point which we need to remember, and all these cases you can complete very successfully if we follow these two. One is to follow the ideal steps of posterior plate cracking. Second is to do the peripheral chop and do the posterior disc at the end. And use of viscoat during surgery, please insist. Endothelium is anyway costlier than viscoat. So please use one or two and charge the patient also. If they're coming so late, means they have to be charged. Your technique is good, but then they have to pay more for protection of their own endothelium. Thank you very much.
Thank you, Dr. Meenu. So we'll take all the questions at the end of the IC because there will be a lot of different techniques, different views for handling different types of cataracts. So
because have you introduced yourself? No. So I will I have to call upon Dr. Amit Porwal, who is the chief instructor of this course. In my stop and chop technique, I was not able to get a good crack. So how do I deal with this? So stop and chop, I think, is the way to go to the next stage of chopping. And so in stop and chop, how do you deal with all this? Over to Dr. Amit, please.
So thank you, Minu sir. And I'm quite sure most of us, when we start our FACO, we start with, I mean, that's what we have been teaching and we have been taught. Start with divide and conquer, then move to stop and chop, and then move to direct chop. So stop and chop is the most preferred technique by at least 60 to 70% of the students. So what I'm going to do when I'm not able to get a good crack in my stop and chop technique. Slides move nahi ho rahe. So this is totally a video-based presentation of 8 minutes, wherein I'm going to cover all the different types of cataracts, which will be a soft cataract, a hard cataract, a sticky cataract, leathery cataract. So everything is covered. So what is important in stop and chop is the depth and length of the trench. This is very, very important. If your depth is not adequate and the length is not adequate, you will end up in not getting a crack. So you can see this was a very complicated cataract, a mid-dilated pupil with a corneal scar and almost a mature cataract. So I'm trying to do the central trench, but this trench was not through and through. The length was not adequate. So I rotated to 180 degree and again I extended the trench. But you see, the length of the trench is less. It is just 5 millimeter. It is within the axis. You will never get a good crack this. So you make sure that when you are going to make the trench, the length should be adequate. You have to go towards the mid-periphery a bit. And when you do that, you have to follow the contour of the cataract. This is very, very important. You can't be scared and just stay in the center and try to just nibble off a few pieces of the cataract and try to get a crack. That is not possible if you have this type of hard cataracts or if you have these sticky cataracts. So this you can see in another video. The axis is done. It's a sticky cataract. Hydro dissection has been done and there's a hydro delineation area also. In this I went up to the periphery. But if you see the depth of the trench, it is deep only in the center. But in the periphery I have not followed the contour of the cataract. So only one punch was given in the periphery, but the whole depth was not adequate according to the contour of the cataract. So I finished the trench over there, and then I continued on the other side after rotating 180 degree. And you have to make sure that the depth is adequate. You can't be just two deep depth wide or one depth wide in the center and then say that I have adequate depth. The depth should be uniform throughout the length of the trench. Then only you will get a good crack. Once you have got a crack, then chopping into multiple pieces is very, very easy. Now coming to the cracking techniques, you have done a good trench. You have a good trench of adequate depth and length, but still you are not able to get the crack. Why is it so? So the technique of cracking, how you are going to place the instruments, where you are going to place, at what depth you are going to place, this is very, very important. Usually what happens is, we are so scared that we don't go inside, we just remain superficial. You can see this trench is being made. I'm going to try to separate this into two pieces with the help of these two instruments first. But you see, when the width of the trench is not adequate, I'm just in the superficial part of the trench and I'm trying to separate these pieces, but I'm not going to get it. So what I'm going to do now, not to panic, use a good cohesive viscoelastic substance. Use two instruments, there's no shame, there's no hassle in using two Sinskis or two choppers. Now in this also when you are using, if you are keeping the tape only in the superficial part of the trench, only the superficial cataract is going to get cracked, the posterior plate is never going to crack. So the principle is when you want to have a good crack, you dip the instrument into the center of this groove, be in the posterior part as much as possible and uniform force either the same direction or the cross direction. Only when you do that, you are going to get the crack. If you are going to remain superficial, you will never get a crack. So most of these patients I am showing you is the mid-dilated pupil, because usually these are the situations wherein we are scared to extend the trench to the periphery. When we get a well-dilated pupil, our visibility is more, so we have the adequate length of the length and the depth. But in the mid-dilated pupils is where we get stuck. So in this case, the depth is done, adequate length, adequate depth. I'm trying to get a crack, but I was not able to. Why? Because this was a very soft cataract and a sticky cataract. So how are you going to deal with it? You have done the central trench, you are not able to get a good crack, convert this into divide and conquer. There's no shame in converting to divide and conquer. Divide and conquer is a very good technique. You don't have to worry. In these soft cataracts, when you have deep bulk, basically by doing the divide and conquer, you are debulking the cataract. So when you are debulking the cataract, you have one crack in one of the quadrants and then you can emulsify it. Again, when you are going to convert into divide and conquer, no shame. Please use two Sinski hooks. It is nothing that you have to always get a crack with the phaco probe and one Sinski only. You be gentle, be slow, because every cataract is not the same. Even if you have done 2,000, 10,000 cataracts, every cataract is a new case, it's a new learning curve. So when you are not able to crack, you have got a proper length, proper depth, you have learned the proper cracking technique, but still some of these cataracts, they really don't separate, whatever technique you do. So this is a very soft cataract. I've done dissection, I've done multiple delineation. Now why multiple delineation? You see the way I'm rotating it. We don't want any additions. Multiple delineations have been done. This was very important. When you're doing the central trench, in this soft cataract, you have to break the backbone of the epinucleus. You have to be very gentle when you're going in the periphery. You see over here. You just need to break the backbone of the epinucleus, not the farthest epinucleus which is there, but the layers immediately below before that. Because when you are going to do that, when you're trying to separate, because the epinucleus is cracked, you will get a crack, but it won't be a through and through crack, but the crack will be there only in the periphery. Even if that is there, it is enough, because you see, there's a crack in the periphery, this is a sticky cataract, you're not going to chop. You can't get a good chop in this because the vacuum won't be hold it. So what you're going to do? Just hold it and flip it into the pupillary plane. You can see this cataract is just flipped. It's a very soft cataract. Now why it got flipped? Because you're converted into multiple delineated areas. So there are multiple small area rings which are there. So you go on emulsifying one ring from the center, and you can debulk the whole cataract. But if you have not done a dissection, delineation, and you only have a dissected, you have done the dissection, the piece is so bulky that it will never get flipped into the entry chamber. Flipping in the entry chamber is an art which will be achieved only when you have done multiple delineations. Sorry for this video was an old video which has a hazy view. But you can see again in this, it looked like a hard cataract. I thought I'll get away. I will do a stop and chop technique. But I was not able to. Even if I want to convert into divide and conquer, I was not able to. So there comes the rescue of basically flipping it into the entry chamber and emulsifying the cataract at the pupillary plane. So you can see this is possible only if you have broken the knuckle of the epinucleus. Earlier it was not broken. When it got broke, the whole piece just comes up into the entry chamber, and you can use the other instrument like a fulcrum to push it into the entry chamber, or to flip it or tumble it upside down. You do that and you can emulsify the whole cataract. So these are the tricky situations which you come across, whether it is a soft cataract or anything. Now when everything you have learned fails, you have a bad day, you have done everything, you are losing your patience because you are in a different, your mind is somewhere else and you are operating, how are you going to deal with it? So length is adequate, depth is adequate, cracking also I'm trying, but I'm not going to get a crack. I have converted into divide and conquer, still I'm not able to crack. I'm trying to do flip the nucleus, I'm not getting a flip. So what I'm going to do? And like a beginner, what I'm going to do is I'm going to debulk the whole central core of the cataract. Whatever type of cataract it is, you just debulk the whole central core in whatever way you want. So basically you are going to create an empty saucer. The whole empty saucer will be there, the whole central core you have emulsified, and then with the help of a second instrument, you can prolapse tumble up the whole saucer. Or what you can do is, you break the backbone at one particular area, you get a peripheral partial crack, and then you can prolapse it. So sometimes you might use a bit more energy, but it is better to use a more energy than to cause any complication, and you always have a dispersive visco which is going to come to the rescue. So you see, I've tried everything here. I've done the trench, I tried the crack, I've tried the divide and conquer technique, but still I'm not getting it. Then what I do? I just debulk, and then whatever central core hard cataract I get in this divide and conquer, only the centrally I split it, and then that whole piece gets debulked. So this is the way you are going to deal with this type of cataracts. Slide Nimori. So this is what I wanted to discuss in my stop and chop. Thank you. Minu sir, we can have the next speaker. So our next speaker is Dr. Krishna Prasad Kudlu. He's chairman, editor proceedings. He's a terrific surgeon. He runs a refractive and a cataract training center in Udupi, Prasad Netralaya. There are a lot of smile people who have been trained by him. There are a lot of people who are doing cataract after they have been trained by him. So Krishna Prasad has a terrific experience, and he is going to talk about his experience in a non-cracking nucleus.
Thank you, Dr. Amit. I think I'll try to minimize my talk as less as possible, because most of the thing has been told by Amit. Nothing is remaining because he is such a fantastic surgeon. We have been part of this IC, probably one of the most popular IC of AIOC. नहीं, ये ऐसे सारी हॉल में ऐसे ही काम करते हैं. It's not connected there. It's normal. It will come and go like this. अब तो कुछ प्रॉब्लम है.
The initial stages. The initial stages when you are going to learn, you should do a crisscross against. So you are going to
Naren,
place like this
Naren, you plug in
and
and
go
start.
crisscross. Because when you are going to separate direct way, when you are going to do that, you have to really be deep inside and you should be able to analyze how much you are going to stretch. Because like this, the amount of stretch force unconsciously will be more. But when you are doing a crisscross, it will be less. So you have to understand that. How much force? Because if you apply excess force, you will get a zonal dialysis or a rent. So you should always go crisscross initially when you are trying to get the first crack in the beginning.
As deep as possible, as deep as you have trenched. At the depth of the trench you have to. The good thing if you have a blunt tip chopper is that you can cover the walls of the trench also with this. So if you are crisscrossing or puddling,
Naren, it has
crisscrossing
come
will give you
like
more,
this.
more freedom of movement, more range of movement. But this wall of this chopper can be, this length of the chopper can cover the walls. That is one good thing.
There is one more chopper available called as Rana's chopper. For beginners, I feel that's the best. That is something like when you eat a piece of fruit with a toothpick, the force is only on one point. So Rana's chopper has two teeth, like a fork. Jagdish Rana's chopper, it has two forks. So when you want to get the crack, there are two sharp points which are going to give you support. So that is better. You can meet me later on, I'll tell you about that. So we'll have Dr. Kudlu's talk.
Thank you, Amit. As a member scientific, Amit, you are doing a fabulous job. Could able to see your hard work in SSTC also. In my direct job, I am struggling and not able to get a good crack. So how do I deal with? So no financial interest. So why direct job? Because it's always efficient. As Amit said that it divides the nucleus in natural plane of cleavage. Definitely there is a reduction in the fake energy, enhanced safety, better control of the nucleus division, it's more adaptable, less ultrasonic time. So coming to the direct chop, I think we all know that very simply to say that there is a horizontal chop and there is a vertical chop. There are a lot of chops has been described in the choo-choo chop, different chop, but just remember horizontal and vertical chop. So horizontal chop probably, according to me, it is more suitable for soft to moderate grade of cataract. Normally, we prefer a blunt tipped chopper, that is like a Chang's chopper or Lieberman chopper. So now my talk is today, if I am doing a horizontal chop, nucleus is not cracking, what I should do? What are the reason for this? Improper placing of the chopper, not impaling deep into the nucleus, and impaling peripheral epinucleus instead of nucleus. These are the three problems you may have, and finally you may land in this problem. See, I am just showing you a video. See, you can see here, holding the nucleus, go just underneath, it's a blunt chopper, but still could not able to crack so much. Still it has been cracked into a half piece, not exactly full piece. So most of us, we try to finish off the case fast. Come on, let us do it. Don't make into a minimum 4 to 6 pieces that make your job easy and that also save your endothelium. That is very, very important. Because every time each pieces comes on, sometimes these all nucleus pieces may hit the endothelium. It may chatter within the antechambers. It may cause a endothelial damage. So then there is one more case I am just seeing. This is a patient with a mature cataract. It is a sort of a Morgaginian cataract. You can see the chopper. It is not exactly blunt, not tipped one. It is not exactly sharp. It's a somewhat semi-sharp chopper. go inside, you try to crack, then it is like trying to do somewhat vertical, in between trying to do something called horizontal, because surgeon is a bit scared. So just go inside, try to crack, not able to crack that much, even though nucleus is of grade 2, grade 3. So always you should go with a blunt chopper, go with a one shot, then you try to divide, then your job is going to become much, much easier. Now you turn the piece around, then I think you can chop it quite easily. So selecting a proper chop for particular case is at most important. So this is a case of, again, case of a hard nucleus. You could see the surgeon who is embedding the nucleus, not exactly, is going much far ahead, try to go inside, still he could not able to crack it. So the ideal case scenario for this one, do a vertical chop. So he is trying to do the horizontal chop, struggling. See, if you struggle many a times, especially grade 4 cataract, chances of damaging the zonules also much, much higher. So struggling, then you could able to get a somewhat average chop. Once the chopping done, I think you can do. Again, I am insisting here, try to make it to more pieces. So this is the one more video of how we exactly do the horizontal chop. You can see the chopper around there. Go within the substance, wherever it is harder side. Always try to select exactly at the entry itself. Try to impel the nucleus. Go underneath the nucleus and you try to chop in such a way that then it will make into exactly into two halves. This is how you have to do. Then most of your job is over, and whatever that energy, whatever you use, which is going to be much, much less compared to the, if you do a improper horizontal chop. So as I said that, impel deep in the center of the nucleus, very important. Go under the rhexis, hook the equator, very important. Move the chopper towards the probe and with the lateral separation. So coming to the vertical chop, normally separating the forces act in a vertical direction, which can be done even in the case of small rhexis, and even you can try in the small pupil also. So vertical chop, grade 4 cataract, small rhexis, small pupil, the best thing. But you have to take always sharper chopper for vertical chop. The most common one is most of us using Nagahara chopper. There are Agarwal's karate chopper. Even my friend Mohan Rajan chopper is also available. So what are the reasons for not achieving good crack? The one is inadequate tip exposure, very important. Not buying deep into the nucleus. Not having a good vacuum. So you need to have a very high vacuum, around 400 millimeters of mercury. Always using the blunt tip chopper, or I always feel a sharp chopper. So this is the case I am just showing you about the vertical chopper. Go impel within the substance of the nucleus, then you try to chop. But here the surgeon is trying and not able to chop it properly. That means the chopper is not going within the substance of the nucleus. So he is trying to chop, but simultaneously with the 5-6 attempts, then he could able to have this chop. So this is very important. Go within the substance, even with the probe and the chopper, then you could able to have a very good chopping technique. Once it is done, again I am repeating, even in vertical chop, when you are dealing with a grade 4 cataract, try to do minimum 6 to 8 vertical chops. Then so you can even have the center core first, then followed by the remaining pieces quite easily. So you can see here the chopper, this is a Mohan Rajan chopper, very, very sharp tipped chopper you can see. See, if you are having a very good chopper, initially the beginners may be little bit afraid by seeing the chopper. Once you become the best, these choppers will do wonders for you while doing. See, even though a lot of struggling he is doing, because he is not embedding. So how you have to do correct way, go within the substance of the nucleus, then go like this. This is the correct way to chop, okay, into the two halves, then you try to rotate, then you turn. This is the correct way to do this vertical chop. So you can see here, it is embedded nicely, and you could be able to have more pieces. Then later on, if the center core is hard, try to hit the center core first, then followed by the other pieces around. So this is the last case I'm just showing you. It will take half a minute, Amit. This is a case of a vertical chop. So you can see the chopper, it's a sharp chopper, but it's not so sharp compared to this Mohan Rajan chopper. So it's a sharp chopper, but the tip is not too long. So especially patient with a grade 2 to 3, you can try this and you can come up with a very good chopping technique. So you can see, make into more pieces, try to eat. In such cases, the amount of damage what you do for endothelium is endothelial loss is going to be much, much lesser. So this is the last video I'm just showing you. This is a patient with a very grade 3 cataract, but it is a brown cataract. You could be able to see a good red reflex. Try to make into different halves and you can eat quite easily. It looks like it's an immature cataract, but it is not immature cataract. It's a grade 4 cataract. So make into more pieces, then you try to have, then you can get the nucleus into the tip quite easily. So take home message, make sure that adequate tip exposure as per the grade of the nucleus. Start sub-incisional so that you will reach the core of the nucleus easily. So the key is start at sub-incisional so that you will reach the core of the nucleus easily. Impel sufficiently into the depth of the nucleus. Chop when adequate purpose of nucleus is confirmed. Bring second instrument linearly towards the probe, then to the lateral separation. Patience is the key. I thank again my brother Amit Porwal this wonderful opportunity. Thank you one and all.
Thank you, Dr. Kudlu. So for the audience, this whole course is totally going to be video-based teaching. There's nothing going to be a theoretical talk. So very wonderful, Dr. Kudlu, for the nice videos. Now we have our next surgeon, a friend of us, Dr. Naren Shetty, a young dynamic surgeon who's heading the Department of Cataract of Narayan Nethralaya and one of the directors of Narayan Nethralaya. He is going to talk to us basically on how to deal with the different techniques of dealing a soft cataract when you're not going to get a good crack. We also have other co-instructors, Dr. Sudeep Das from Orissa and Dr. Haripriya Arvind ma'am. She is my teacher, mentor from Arvind, and she's got a huge fan following like Dr. Meenu of cataract surgeons. They have taught enormous cataract surgeons around. Over to you, Naren.
Naren is the only one surgeon who can operate in both the hands. For right eye, he operate in right hand. For left eye, he operate in the left hand. So I'm a unique surgeon. Over to you, Naren.
Dexterity should be there, which is very important for a cataract surgeon. When you start surgery, start eating from your left hand also. And I think Naren is a perfect example. He'll teach us how to do in both hands.
Thank you so much. I think on this onset, I would like to thank Dr. Amit and AIOS for giving me this opportunity. See, today's question is, can we actually chop soft cataract? The answer is yes, definitely you can. It all depends on the right technique and the right instruments. So I have designed this particular dialer. No matter what grade of cataract, I use the same dialer for the hardest of the cataract and the softest ones, just one second instrument, and I don't change it. So how do we do, or how do we chop soft cataract is, the best way is obviously is a mechanical chop. What you need to do is take the phaco probe, keep it in the, almost at half the depth of, I would say half the depth of the lens. And then what you do is you take your dialer. That should also be a very deep chop. A lot of times we do a very superficial chop and that's when it goes long. And when you're moving towards the tip, it should be a quick movement towards the tip and slow lateral separation. The slow lateral separation is the key. It's very, very important because we are always in a hurry. If you do it quickly, you'll just cheese wire and there won't be any chop. So let's see how it looks like it. So once you do the lateral separation, you can see the speed at which I'm doing extremely, extremely slow. You have to maintain the speed, otherwise it'll just cheese wire. Again, I'm just going to rotate, position my phaco probe, a deep chop towards the tip, and slow separation. Hold, separate, and just hold. The pieces will separate eventually. So if you just do this automatically, all the pieces can be chopped. And if you observed, I've kept my phaco, the bevel of the phaco probe to the right. Why? Because it acts like a hand. It increases the surface area so that I hold that lens and then I can separate it. Then once it's separated, I think everything else is pretty simple. So this can be repeated for every surgery, every soft cataract. Again, most of the time it's without any vacuum or flow, or sometimes, you just a tinge of vacuum and then immediately come to irrigation, and then you can do your chopping. It's very, very easy. The only thing very crucial is the depth. The second thing is the lateral separation, the slow lateral separation. Always remember. Now, some scenarios you can always do a small trench like this, and then once you have done that, you can place it in the depth of the trench and then slowly separate it. Now, other ways to handle a soft cataract also is to purposely do a saucer. So how do you do this? First, you clear off the central piece or central area of the nucleus, and then the adjacent central part should be removed. Do not touch the epinucleus or cortex. Once that is done, then you go with the epinucleus and cortex and remove it. So again, you can see me here. So I've removed the central part. Now slowly I'm removing the mid adjacent area. Once you have done that, you have a nice bowl of epinucleus and cortex, and the piece automatically comes to you. In this particular technique also, it's once you get a hang of it, it's very easy. But what is one thing you have to keep in mind is you're going pretty close to the posterior capsule. Basically, you're going very close to the capsule. Now the same thing here, I've removed the central piece and then adjacent area. Once that is done, the piece comes as a whole. So now there are scenarios where you can have a plate like this, right? And how do you handle it? You take your dialer, go below the plate. While you're trying to lift it, turn on vacuum or flow, so that once the piece touches the tip, immediately it'll suck it, hold it in place, and you can remove the whole plate as it is. So it's important to keep the vacuum or step 2 on when you're lifting the plate. Now, to handle these soft cataracts, I've introduced and basically I've come up with a new technique. I call this the smile technique. As the awareness of cataract in India among patients are growing, more and more soft cataracts, are coming to us. We are handling much more soft cataracts. So a technique which is easier, simpler for any mature or an amateur surgeon to pick up is the need of the hour. So this is what the smile technique is. Doesn't that bring a smile on a face? So let me show in slow motion. So how do we do this is, you take the bevel, this is a 45-degree tip, the bevel should be facing down, and keep the highest vacuum and highest flow settings in your phaco machine, provided the chamber is stable. Once that is done, you start superiorly along your rhexis, turn on step 2, and then go along the rhexis margin, right, to the inferior, so in a smile fashion. So this creates a smile trench, and because you have created a smile trench, it gives area for the temporal part of the nucleus to be sucked when you go back again in the smile fashion, and then once you bring it back again, the whole piece is out. So it's very, very simple technique. Now, why choose this technique over other things which I showed? As you know, it just takes about 14 seconds to perform this particular surgery. It is a single-handed technique. You don't need special skills to perfectly maneuver second instrument, your phaco probe, the depth, and so on. It's a lot of technical things which you need to follow to do the other techniques. Now, in this particular technique, high flow and high vacuum is used so that all the pieces come to you rather than you go after the piece. And because if you go after the piece, you tend to go very close to the posterior capsule, and you can end up with a PCR, which is very common, which happens in a very soft cataract. Now, again, I want to stress the fact that even though you're using high flow, high vacuum settings, you have to make sure the chamber is stable for your machine, because each machine can handle certain high vacuum and flow. So just be aware of this. And the next thing is, throughout this technique, the phaco tip is always kept at the level of the anterior capsule. And it's because it's kept at the anterior capsule, it's away from the posterior capsule, and again, obviously, it's away from the endothelium. That's why you protect you prevent PCR, and also you protect the endothelium. And because of the high flow and high vacuum settings, you hardly use, or there is no phaco power at all being used. Again, you protect your endothelium. So there are different ways you can actually handle soft cataracts. I hope after this session, the soft cataract will be not too hard to handle. Thank you so much for your time.
Thank you, Naren. So our next speaker, Dr. Sudeep Das, he's going to talk on when my rhexis has extended or torn and I'm not able to get a good crack. So how do I deal with it? So we all teach our students, when your rhexis is torn or extended, don't continue with your phaco, convert to SICS. But we have a terrific surgeon who's going to teach us, even with the toned rexes, you are going to do a phaco, and when you are not going to get a crack in that case, how you are going to deal with it. So Sudeep is a terrific surgeon, a high volume cataract surgeon, and he doesn't need any erection, any introduction. He is one of the high volume surgeon in whole of East.
Well, can I add one point in this horizontal chopping? Please try placing the chopper first in the periphery and then holding the nucleus. That is another way of doing it. So if you feel, sometimes when I do it, when I hold it first and then focus on the chopper to go under the rexus and place it in the periphery, I sometimes lose hold on the nucleus. Then I have to again impale it and then do a chopping. So if I go other way around, I go place it in the appropriate position. Sudeep, get ready. I am just filling up.
I'm ready.
Oh, you're ready, but nothing has come up there. So if you keep it in the periphery and then if you hold it, then possibly you may not lose hold there. Try that please and then select which one works well for you.
Okay. So I have no financial interest in any of these. So
Can we have the mic closer? Your one mic is off. Audiovisual timer, please.
yeah, it's running. So basically, I had to really struggle to get videos. I mean, you go through this, but very often it's not recorded. So this is quite a black cataract, as you can see. And in these, the problem is, even if you use blue, trypan blue, you can't really see the rexes because there's no contrast between black and blue. So you really don't know what's happening for a long time. So this is my standard technique. I sort of do a big crater as deep as possible. Earlier I used to do a deep trench and try to chop. So now I try to remove as much of the bulk of the hard nucleus as possible. And then start to chop. So this is a very long chopper. And again, I seem to have got at least a partial crack there, but it hasn't really gone into the center. And so that's why I'm trying to trench a bit more. And I'm trying to sort of dig into the nucleus as I can. So you can see here that the rexus was still intact. So I'm taking care that I don't tear the rexus, which is very common in these. But then it's sometimes, the force needed to separate the nucleus, the nucleus slips from the phaco tip, as is happening many times here. So this is just viscoat. Again, no financial interest in that. You need to use a lot of viscoat in this for the energy that you use. And here I realize, for some reason I chopped that and then there was a slight red glow and I realized that the rexus is staring there. You can see a bit, so I thought, okay, let me keep holding the nucleus like this and try and complete that into a rexus. So I go in with my micro rexus forceps. Holding this with a sort of a Sinski hook. And I try to complete this because that is where I'm doing my chopping. So a little bit tears, but I'm not really convinced that it's worked that well, but I can't see that edge anymore. So I thought, okay, let me continue with the phaco. So the rexus tears somewhere here, on the right side, that's the safest because I won't have any manipulation there. So now I realize that the rexus has gone to the periphery. And that's why I decide to sort of not do any manipulation in the bag. But it's like petals, it's sort of broken up. And I'm using a lot of viscoelastic, haven't shown it. So basically I'm doing all the manipulation now. That part of it outside the bag, because every time you stretch, otherwise the bag stretches and the rexus can go behind through the equator into the posterior capsule. So I'm sort of lifting that part out, tilting it out of the bag, and I'm sort of trying to emulsify these petals. But this I'm able to do because the chops have gone almost up to the center, so that at least I can lift up those little petal-like things. It's very hard, but I can lift them up. So this wasn't a rhexis which ran away right at the beginning. It happened because of the chopper itself. I couldn't see the rhexis, the capsule, against the very dense nucleus. And though I was taking precautions, you know, sort of rubbing it against the nucleus, even then it can tear. So anyway, in this I was successful in removing this. Basically I'm doing out of the back surgery, but I'm not removing the entire nucleus out. So most of the nucleus remains in except for that part, and using copious amounts of written sort of dispersive viscoelastic. In the next one, I was not that lucky. So again, it's a very, very black cataract, and the pupil is not that ideally dilated. So here it's even more difficult to chop. And this is an earlier surgery where, if you see, I've just done a deep trench where it becomes very difficult. You can sort of crack in that area, but the other areas become very difficult. And in the pupil, you can see the amount of chaffing that has happened because the pupil came down. Then I decided to put in the iris hooks, so I see what's happening. And that's when I discovered that the rhexis is torn. So I'm not sure whether it caused the tear because of the hooks or it was already torn, because it's exactly in the region of the hooks that there's a tear is there. So again, I thought that, okay, let me sort of try to lift it out of the bag and continue with the surgery. But unlike in that case, the chops are even worse. It's not really that great. So it seems to be going all right. But you have to remember that because the chop is not great, the other part of the nucleus is sort of pushing against the PC when I lift it up like this, much more than in the other cases. So while doing this, at one stage I suddenly realized that the PC is gone. The tear has, this is where I realized that the tear has gone into the PC. So I sort of thought I'll implant a 3-piece IOL. So that's what I did, 3-piece IOL in the AC behind the nuclear bits. It's already sort of broken up now. And now we want to remove the iris hooks because I want the pupil to sort of close down a bit if possible. Don't let the pieces get behind the IOL. And then I remove these bits. And once that's done, I sort of implant the haptics in a safe zone in the sulcus. So I try right angles to where the PC has torn. And then, I mean, that's basically the surgery. And nothing had fortunately gone behind because of the viscoat and the IOL. Thank you.
Super, Sudeep, you have nicely shown. So, our next speaker is none other than Dr. Jeevan Tidyal sir. We all know him. He is the head of RP Center. He is known for his tremendous work, for his publications, for his books. He is going to show us a very nice technique. So, one thing which I wanted to mention, when you are using a chopper, whether you are using doing a horizontal chop, direct chop, stop chop, the length of the chopper is very, very important. We usually get scared and we use short length chopper. Whether it is sharp tip or blunt, always use a long chopper. So Mohan Rajan's chopper is really good. It is long, it is about almost 1.75 millimeter. With the sharp point, you can get good penetration and then you can get a good crack. If you are going to do a horizontal chop also, the chopper length should be adequate. It should, even if you want to use a dialer also, make sure that it is long enough. Because if it is long enough, you will be able to get a good cut. And what Sudeep showed is videos. So this is for people who are in trouble. So Sudeep is a terrific surgeon, black cataract, he managed with the axis tone and all. But you all see how well you can manage. If you can manage, go ahead with your phaco. Otherwise, the normal dictum is convert, and please convert to an SICS. You can put a foldable IOL, a 3-piece foldable IOL. You can do an SICS without any problem. And in all this learning curve, always use dispersive and cohesive visco both. So you are ready?
Just one comment on cutting the capsule or the rexus when you are trying to or prevent it from cutting your capsule is whenever you take your dialer to go and chop, what you have to do is start from the center, make sure the tip is very close to the capsule or cortex, and then slowly go to the periphery. If you create this habit of going down in the center, go to the periphery, chop. Go down to the center. If you do this, then it's automatically the less chances of you actually going above the capsule and then chopping. Because if you go to the periphery from the top and then you go bottom, very highly likely you're going to cut your chop, especially if you're not able to see your capsule. So
Okay.
Yes, sir, is going to talk
Good
about
afternoon, friends, and thank you, Amit, for making me part of this important instruction course, because cataract surgery is, we all been doing in a correct way. And I think, if we give some points which we can always analyze ourselves and try to do that, maybe things might improve. And posterior polar cataract, you all understand, we always worry about the type of posterior polar cataract, the posterior capsule getting dehiscent during your procedure, and the most dreaded would be if you have a drop happening in these cases. And that is where the examination is very important. Assess your cases properly, especially the integrity of posterior capsule, and look for a hardness of nucleus. Examine the other eye also, which is a very important point for any cataract surgery, which is really important. Classically, we have been taught about slow motion phaco, layer by layer emulsification of central core of nucleus, do a nice capsular axis delineation, and subsequently do a sculpting and chip and flip. The two things we have learned here, one is don't do hydrodissection and do a layer by layer emulsification if you're slightly harder nucleus. If you're soft one, just do a sculpting and chip and flip technique. This takes out the endonucleus first and retains the epinucleus core which you have created by delineation. And normally you don't have to rotate in this technique also. Softer nucleus are easy to manage if you do a good delineation, and chip and flip works very, very nicely in these cases also. But what to do once you have a slightly harder nucleus where things can be difficult? So these are three classical morphology of posterior polar cataract where you have more chances of posterior capsule opening during your procedure. So one is a conical shape like this. This is the anti-subsequent OCT picturization, or your moth-eaten appearance, or you have an ectatic appearance. Luckily, these are seen in around 10% of your total posterior polar cataracts. So it seems that around 10% of cases you have a difficult situation. 90% of cases you will do a routine surgery, you will come out in these cases also. The similar picture you can see in a intra OCT also. So what to do when you have a little harder nucleus, and how to do where you are not supposed to do a hydrodissection, not supposed to do a nucleus rotation also, and how to perform surgery is very important in such cases also. So there it is always important to look for a safe nucleotomy pattern. So this is the pattern we have described, chop and tumble nucleotomy where rotation is not required. And you can simply do a delineation, like similarly we are doing a hydrodelineation here, primary core, secondary core, and you'll see the endonucleus separated from the epicortical cushion, because cushion has to be made. So once you do a delineation, cushion will be made, and sometimes this delineation is not complete and rotation becomes difficult. So this is the technique which can be done, easily practiced in routine cases also. So do a central sculpting a little bit so they can hold effectively in the middle or deeper, then do a chop here, because nucleus cannot be rotated. You can see here, take another piece of nucleus from here, and this is free now, take out this piece. So this will give a space for an internal hydrodelineation to happen, and that will separate the core more easily. Now I can tumble the piece to the center here with my instrument here, and this piece has come and eat this piece also. So this technique can be done in a difficult situation like subluxated cases, small pupil, where you have not done good hydrodissection delineation also. This is a very effective way to do it. The entire nucleus has been emulsified without the disruption of an epicortical cushion. Subsequently, you can take out this cushion, pull it from periphery to center, and you can take out easily also. So that is a classical way to look into these cases also. This is again to simplify here. Once you do a chop, so you'll see in the OCT picture, there's a multiple hydrodelineations happen here. So this deletion gives a space here, and this fluid will seep into the core you have created earlier and makes things simpler for us. And you can complete the surgery effectively like you saw in the cases also. And this retention of epinuclear cushion till the end is a compulsory for all cases, more so for cases with a nuclear hardness, and the PC may be little thin or defective in these cases also. Just to show a similar case here, you can see the OCT picture, conical shape. This classical picture of typical posterior polar cataract, where things can go wrong also. So this is a classical posterior polar cataract which you see, and the first thing comes to the mind with this case, I can do a complete surgery or not. If there is a defect, how to manage such cases. There again, you can see a moth-eaten appearance here. The importance of doing safe nucleotomy comes in picture here also. You can see I was doing a delineation here. During the second delineation, I could see the posterior capsule open. You can see this flutter happening. Also, again, you can see the flutter. That means there has been a breach into the posterior capsule in this case. Now, again, I can't rotate the entire complex here. See, I'll just take out a piece here, trying to make sure my core is separated from the epinuclear cushion. That is the final way of thinking. Subsequently, the entire nucleus can be just shifted by your second instrument to central area and keep eating. Then towards the end, you can take out the epicortical cushion, which was safeguarding the nucleus being dropped. You can see a large central opening, this is the classical opening seen in the posterior polar defects, which is normally linear and they look like elliptical opening. So this is the typical you see, unless you damage the, with your surgery, which is appearance a little different than this here. Tamponading with dispersive viscoelastic, you can put the lens over the rexus surface because you have an open PC here and intact visitor's face. You can just tuck the haptic underneath the rexus margin and lens goes inside. You can complete the surgery effectively. So what we have seen here, if you identify the problem, you can manage better. In fact, most posterior polar cataract you can manage simply without having to do a vitrectomy in these patients also. The other important way of doing a similar technique is a femtosecond application. So this is our technique, which is hybrid technique. Dr. Abhay group had described the rings of safety, 1, 2 rings of safety. We have described chopping also. So this is a hybrid in a slightly harder nucleus. So this is around grade 3 nucleus. You can see the posterior polar pattern. So once you do a hybrid pattern, you have the chop, you have the delineation happening in 3 areas. So this is primary segment, secondary segment. All segment can be taken one by one. There's no hydro procedure done here. Once you separate the pieces, the bubble comes out and internal hydro delineation happens automatically, which has been created by femtosecond laser. So I've taken out the second layer of a nucleus with just by second instrument, peeling off the pieces to center. You don't have to go with the handpiece. Again, this is a third block of nucleus fragmentation being taken off. Entire lens safety is there because the cushion is intact till you completed your emulsification. So this technique can be translated into a normal surgery by a chop and tumble technique also. So I would say, to summarize the technique here, idea is to safeguard your nucleus getting dropped in a difficult situation. There cushion comes into safety-wise also. This technique is very, very useful for posterior polar cataracts in a difficult anatomy, morphology-wise. It is safe, effective, and it, very importantly, you can do the surgery in an effective manner where you can safeguard the posterior capsule, retain the epinuclear cushion, and do an effective nucleotomy in these patients also. Thank you for your kind listening. This is a new book which is being released in AIOS, making IOL power very simplified for you people in your hands. Very small book and very handy with JP with this. Thank you again for your kind listening.
Thank you, sir. So we'll take our next talk by Dr. Haripriya Arvind ma'am. She's going to do a talk on how to ideal a rotating nucleus of a hypermature cataract. So hypermature cataract, tone, rexis, these are the advanced talks which are there once you're confident with your phaco technique. So hypermature cataract nowadays very rare to get, but we do get them, and how we are going to deal with it, Dr. Haripriya ma'am is going to talk about. So keep your questions ready because after this talk we'll have very less time to discuss. So we'll give quick answers to all your doubts. Might be some of the points, as sir told, we all are terrific cataract surgeons, but sometimes one particular point, the take home one point helps us a lot. So this is very, very important. Minu sir, anything to add?
In vertical chopping, we are not ideally supposed to move the chopper. Ideally. But sometimes if it is very hard, I make an oblique movement. There his point comes very crucial. Moving from the center towards a little beyond the rexus margin, not towards the periphery. Periphery you will hit the capsule. But movement is good in an oblique kind of movement. But from center to, but otherwise stay at the inside the rexus margin itself. And remember where you have done the sound. If you, Sudeep has shown the peripheral chopping, which I had shown in the beginning also, same thing, you need to pull the peripheral nucleus into the center and then chop. Our tendency is to go to the periphery and then cut. Then is the time when you cut the rexus margin.
Thank you, Amit, for the opportunity. We had some excellent videos. I wonder if Sudeep ever does any non-brown black cataracts, looking at all his videos. So I'll be also showing some hard lenses. As we know, hypermature cataracts, the nucleus core is very hard. So in a hypermature lens, what we do know is that the cortex reaches a hyperosmotic state, and this is what makes the lens capsule very tense. And this fluid cortex tends to settle in the bottom, or you could just see a complete white reflex. And the nucleus is very hard, and therefore complications are also common because the capsular bag is empty. The challenges would be that you have difficulty in visualizing the rexus margin. The second is that the rexus can extend, again for the same reason. And the endonucleus is very dense. So of all the hard lenses, the hardness of a hypermature lens would be the hardest because the fibers are actually packed quite closely. And the nucleus is mobile. So it's very difficult to chop on a hypermature lens. But having said that, that's the only technique possible because the lens is mobile, you can't trench. So which means you can't do a divide and conquer or do a stop and chop. The only way, if you want to fake a hypermature lens, would be a chop technique. And again, for this, because of the hardness, the corneal health is a concern. So as the previous speakers mentioned, a good dispersive viscoelastic is invaluable. The capsule is very thin, very flyable, so which means the chance of PC dent is higher. So just to show, this is typically how difficult it can get. The nucleus tends to tilt, it's a wobbly lens. So the first challenge would be to have a good purchase. How do you get a hold on the nucleus? Once you are able to get a hold, the second challenge is to get that first chop, because the first chop, because the nucleus density, though it is a much smaller lens, the fibers are so packed that for us to go all the way down and then separate the fibers becomes a challenge. So once you're able to get a hold and do the first chop, the rest of it then would be a little more doable. So of course you have to ensure you have a high molecular weight viscoelastic, use sustain for sure. And the settings use high flow and vacuum, and again at a setting where you have a very stable chamber. We do not want to have any kind of surge here. A 45-degree tip, if you use one, would be helpful because that gives you a better cut. And have more of the tip exposed. I'll be showing you in the video as to why that would be useful. And your energy has to be optimal. There's no way you're going to be able to cut these nuclei using less energy. Use the a higher energy as you, and these are probably better rather than trying to use lesser energy and doing a procedure for longer. Using a higher energy, higher vacuum, and getting a good, better grip would be useful. A vertical chop technique, and I agree with Dr. Amit's comment. I would also use the Mohan Rajan's chopper here, the long one. You have two sizes. The longest one, 1.75 with a sharp tip, works well as it would for the hard lenses. So this is a case which also has some fibrosis on the anterior capsule. So use a lot of viscoelastic. If possible, you can even do it from the side port. And the actual nucleus density, you can see only after you've opened up the capsule. So be very careful about doing a rexus because you obviously have to have a rexus if you want to continue with phaco. Otherwise, again, you will just have to convert. That's the best option to go. So to get the first purchase is important. So you can see the tip about 2 millimeters exposed. So you'll have to use energy, go all the way down, and almost the entire tip is covered. So that's the kind of depth you'll have to get a good purchase. So to be able to lollipop this nucleus. So go all the way down, and the nucleus will tend to wobble, but you'll have to continue to deliver the energy. And once you have the purchase, continue to have the vacuum. So you can see it's about 540, 550. 550 is my maximum. But don't release the vacuum until you've actually chopped. So until you've seen that actual separation of the fibers. So hold it down. And then as you're stabilizing it, you will have to probably repurchase if you lose the hold. And then separate because the bag is empty, you have space. The bag being empty also means that you can have a PC rent or a dialysis, so you'll have to be aware of it. That's why the chamber stability is so critical. So you want to go with high vacuum and flow, but not to compromise on the fluidics. That's something we'll have to have. The IOP here is set at 60 because this machine permits us to have a target intraocular pressure. But if not, you will have to use your maximum bottle height, so you have that well pressure and you are able to use high parameters in this case. So that's something you'll have to do. The cutting has to be good. If you're using torsional, I use 60 with the balance tip. Otherwise, you can use the post ultrasound if you're using a standard ultrasound. So, like I mentioned, the Rex's size, you don't want to make it too small because then you can't bring the pieces out into the AC and phaco. Again, you don't want to make it too large because then the whole nucleus wants to come into the AC and then there's nothing to hold it back. You're too close to the endothelium. So again, this is when you actually see the actual density. So don't be fooled thinking that hypermature lenses, maybe it's white, it's not going to be so hard. Definitely they're all going to be hard. If it is a hypermature cataract, that is a given which we have to work with. Take some extra time and do the Rexes. And again, have more tips. So retract the sleeve well, have the tip well exposed, and use a new tip. If you, or you have a few tips just kept set aside for these hard lenses. There's no point trying to use a blunt tip, then you won't get that good purchase. And I would like to normally complete the first chop and then go on to the sub chops. So I would actually like to chop it very small, you know, when I do any phaco chop, but in a hypermature lens, you can't do multiple fragments in the first go. So I will be happy when I do either a 4 or 6 piece chop initially, so at least I have those other pieces to support it laterally when you're chopping. All of that helps. Again, the bag is still loose. It's not like it's going to help to hold it in place, but at least you have that amount of lateral some support to do it. So about a 4 or 6 piece chop is important. You obviously have to sub chop it later, but that first chop, but the first separation is important. So once you have chopped them into the pieces, to hold on to these pieces, use the side of your phaco tip, use the side of the fragment that will give you a good hold, and then make it into smaller pieces. So this is what is going to make these fragments malleable. Otherwise, it's going to be very hard and you will have more chatter, especially with some phaco systems. So you will have to ensure that you make it smaller. This way, the absorption is better for your cornea post-op day 1. Again, ahead of time, you will still have some edema in these patients. So tell your patients that your recovery may take a few more days. Use the good viscoelastic. Try to stay at the iris plane. You do not want to go into the anterior chamber, except maybe for the last piece where you're too close and the whole bag is empty and the PC also may be trampling, the zonules are weak. Otherwise, try to stay on the iris plane and step down your parameters for the last piece. Again, it's a higher chance in these. The bags are also very friable, so you would probably want to go with low parameters for your last piece removal. So in conclusion, focus on these steps, have a complete Rexis, good protection for the endothelium, use adequate energy, please remember this is so critical. So you'll have to have the sleeve retracted, go deep, get a good purchase, and the lens will flutter, but you will still have to continue to deliver energy, hold on to it, continue to hold vacuum, don't let go of the grip, and then use your chopper, continue to have vacuum. If you lose control, go back, get a purchase, separate until you break the other fibers, and then continue with phaco. Thank you.
Thank you, Dr. Haribia ma'am. So now we have last few minutes. We are ready to take questions. If anybody has any questions, the whole panel is there to answer. Yeah. Can you come to the mic, please?
Likewise, you have said, you have discussed about 2 types of chop, horizontal chop and vertical chop. So my question is that for the beginners, what should we have to proceed? Either we should start for vertical or should for horizontal and move to vertical, or different surgery we have to use different chopping?
I would really say is vertical is better because horizontal needs more technique. Otherwise, 100% you're going to damage the zonules or cut the capsule, something, because you have to take it really to the periphery and then chop. I would really suggest to be right in the center in the beginning at least.
So you have always learned horizontal and vertical chop. There's something called as a modified chop. So always try to do a modified chop. Modified chop is what you just do a bit of trench and then do the direct vertical chop. So this chop gives you better control and it has a lower learning curve and it has more safety. So I would suggest go for a modified chop where you do a central trench and then do a chop.
So, and also what is very important is whenever you're chopping, the starting point of your chopper or dialer, where you touch the lens and bring it towards the tip, it should be very close to the phaco tip. See, if you're trying to tear this page, if you're holding here and trying to tear it here, it's not going to happen. It has to be next to each other. Your fingers need to be next to each other, and then only you can tear it. But otherwise, it's very challenging. So that's why your dialer for NS2 and above, doesn't matter what the grade is, for NS2 and above, keep the dialer, the starting chopper or dialer, the starting point should be just in front of the tip, and then you should move towards and slightly beyond the tip, and then sideways. If you look at even Dr. Haripriya ma'am also was doing the same. So it's important to have that. That way, the lens won't rotate. Now I'll give you another example. If there's not much of material there and it's a Morgangi kind of cataract, if you're again trying to chop like this, it has a tendency, if you're holding the center, this is the phaco probe and this is the chopper or dialer, if you're trying to chop, it'll rotate. But if you keep it closed, less chances of it rotating, right? So that is something to keep in mind.
Two important things you have to make sure, what Dr. Haripriya also mentioned. Your tip has to be exposed nicely. Your tip should be well exposed, your chopper or the dialer should be long enough. If your tip is well exposed, whether you do a stop chop or a direct chop, you will get good embedment of the nucleus. When you stop chop, you will get a good groove without any obstruction. So the exposure of the tip and the length of the chopper is very important. Yeah. No, everybody has it. Appa has it, Epsilon has it. It's a very nice chopper. Yeah, everybody makes it. Yeah, his name is there. Yeah, we can have your question. We're just running short of time. Yeah. Chod do.
Okay. So it's excellent presentation by all the speaker. So Sodip sir, do we have any ideas? Because the diabetic cataract, they have got the leathery fibers too much. So very difficult. Try all manuals, but you will not see the crack posteriorly. And again, they interfere well, impaling the nucleus in this. No, whole nucleus come. So do you have any alternative techniques that say some suggest tumbling, whole rotation?
I'll just answer it. We are running short of time. I'll just answer this.
Yeah.
In this type of cataracts, what you can do is, we all demonstrated hard cataracts, flower petal chop. What is flower petal chop? The central core is intact,
Right.
that is leathery, so you just cut in the periphery. So your periphery is separate, chopped into multiple pieces, the central core is there. Now you go and embed one piece, as Dr. Minu was telling, push it towards the center. You pull it towards the center with your horizontal chopper, which has a posterior curving cutting edge. You are pulled, you go behind that piece and cut it out. That's the way you are going to separate all the petals, and then what is left is the core. Okay, we have to hand over the hall to the next presenters.
Okay.
Thanks a lot. We'll just take a group photograph for all of the speakers.